Hey there, guys. Between two teeth, we usually don't talk about teeth, but today you're in for a special treat. We're talking about teeth, we're talking about oral maxillofacial surgery and periodontics with our good friend from the podcast Everyday Oral Surgery, Dr. Grant Stucki. Please give a listen. Well, Grant, thank you. I'm Bobby.
I was going to say, I'm Stephy.
And we're Between Two Teeth. We've got a YouTube channel and a podcast. I can't believe that he invited us back after... we had so much fun the last time we talked about our service mission for Ukrainian citizens.
It was an absolutely phenomenal experience. So thanks so much, Grant, for having us
Yes.
back.
So what are we
That
talking
was
about
cool.
today? What's on the agenda? What are we getting into?
Well, this one may make some of our oral surgery listeners a little uncomfortable,
Good.
but we're kind
We
of
like
trying.
uncomfortable.
Yes, I do too. I love awkward situations. I love Curb Your Enthusiasm with Larry David. It's like the whole show is
Yes.
built on awkwardness, and I think that's where we're going today. And the topic really is how can an oral surgeon get along with and utilize a periodontist, and how can a periodontist utilize an oral surgeon in their practice, and kind of vice versa.
Boy, we'd like to know how that can happen too, because
Yeah.
we're an oral surgeon and a periodontist that work together in the same practice.
Coming in hot.
Yeah, there we go.
Yes, this is fantastic. So, I would maybe set the stage by saying, as we all know, there's traditionally, it's an oral surgeon in its own office and a periodontist in their own office, and kind of doing their own thing, trying to avoid each other. There's some of this overlap, especially with implants in the last several years, and kind of both competing for that. And so there can be some competition, maybe some hard feelings there. But I think with the landscape changing in oral surgery and so many practices being bought up and turned into kind of DSO, bigger models, it's much more common now for an oral surgery resident to join a larger practice where there is a periodontist involved, and it's kind of a multi-specialty thing along with GP. And so I think a lot of oral surgery residents, maybe I'm wrong, but we had a perio residency next to us in the same building, and we would occasionally do an implant conference, but we don't really do much with them. We don't refer much to them, and we kind of try to keep our distance, that type of a thing. And so my first question to you guys is, how do you really work together and utilize each other? What do you guys refer to each other, and how does that help you?
Well, Grant, I gotta say, I'm so appreciative that you are kind of taking the leap and having the conversation. I think when you have two different specialties with two different lenses coming together, I think communication and tough conversations like this are at the foundation of a successful partnership. And, Bobby, did you want to kind of start us off?
So I like that where you said communication and sort of trying to get a sense of where you're coming from, where the other person's coming from, where the rubber meets the road for us. We figured out in our multi-specialty clinic that if we can work better together, it's better for the patients. At the end of the day, if everyone's fat and happy and they're busy enough, and you're doing the right thing for patients, then you can learn a heck of a lot from one another, and you can be better. That's going to require you to have an open mind. It's going to require you to break down past misconceptions. As an OMS, a lot of people do what we do, and we can learn from one another, and multiple people can have a role to play.
Right. And just to kind of add on to that, I think Grant brings up a great point in residency. In my residency program, just like you're kind of talking about with yours, Grant, we had our oral surgery department right next door. So perio and oral surgery, we were neighbors.
Did you guys talk to each other?
We tried not to.
We tried not to talk to the periodontist as well. You're the first periodontist I've actually talked to.
Well, unlucky you.
Unlucky you.
Unlucky you. And it's tough. I mean, for a variety of reasons. When you're in residency, it's a tricky spot from an ego perspective. You go from being a top dog in dental school to the bottom of the totem pole, and especially, I gotta say that I think surgery in general, or surgical specialties, they attract a little bit more ego. I don't know if that's the
I have
if that's
no
a-
idea.
an
No, I have no
appropriate
idea what you're
statement.
talking about. I've never met or messed with an ego,
And
including
so
myself.
there's a lot of growth on not
Yeah.
only on the person side of things, but also growth on your surgical technique.
Yeah.
If you make a mistake surgically, those are immediate long-term consequences for the patient.
Can I say my quote?
Yeah, go for it.
Oral maxillofacial surgeons don't use enough sutures. Periodontists use way too many sutures. Somewhere in between there is probably the ideal. Bob McNeil, March 2024.
That's hilarious,
But it's a true statement. One of the first
I think
things
in the broad strokes of things.
one of the
yes.
first things that happened when you came into the practice, and to back it up a touch, we had a multi-specialty clinic, we had ortho, we had endo, we had pediatric dentistry. For some reason, we couldn't find a periodontist that wanted to come into the process.
I think there was a tricky oral surgeon in the
Yeah, I
building
think it
that was
was
hard
me.
to work with.
Yeah, it was
I think
me.
that's what the word on the
They're
street
Yeah,
was.
that's literally the word on the street and on the sign. But so we needed a periodontist. I had some really good friends, colleagues who were periodontists, and I said, we're looking for someone. They both named you, surprisingly. I don't know how that happened. But so you came in and you're like, oh my gosh, the sutures you have are disastrous. And one of the first things we did, I upped my suture game, and we've gotten to a point where, I am much better at doing what I'm doing just based on that very simple thing of seeing materials that you use, bone grafting materials, membrane materials. That was awesome.
As dentistry gets more and more competitive, patients are looking for better results that are more predictable. I couldn't think of a better time than right now, with the business landscape changing how it is, than to combine both people under the same
Yeah.
roof and both specialties to try to get the best for patients with two different approaches.
Well, and here's the deal. We talked about residency. We sort of train within a silo, and, opportunities move, silos don't move. And if you're stuck in a silo, you're going to have problems. I know you did the Harvard Surgical Leadership Program through Harvard Medical School. You're the only dentist in a program of surgeons from all over the world.
Yeah, all over the world.
And you sort of got a global view of how different surgical specialties are working together.
And it was instructive for me because the communication challenges that perio and oral surgery may have, it's not specific to us. There's of course there's other surgeons and other surgical specialties not only had difficulties communicating in this program, but also across countries. There also ended up being political differences among surgeons, and so you see really quickly, man, if we can solve one of these problems, why can't we solve a lot more?
You're not wrong, and I found the same thing. I did a healthcare management leadership MBA. It was all physicians, and just seeing how neurosurgeons and orthopedic surgeons versus internal medicine docs and psychiatrists, it gets back to what Grant's talking about. And what you said, Steph, is communication. You are going to disagree on a whole lot of things. And if you are in a group practice setting, if you don't appropriately communicate or seek first to understand, why is it that you do this, or why is it that you want to do this in the practice, it can really set you up for disaster. And we probably shouldn't let people think that this has been an easy go.
So segueing into that, it's all about trust. And so if you are an oral surgeon going into practice with a periodontist, the first thing is there has to be some ground rules, and you want to trust each other. Specifically, the most basic is to not throw each other under the bus, especially when it comes to patients. And although as a dental community at large, I think we all try not to do that. but having a coffee with your periodontist and throwing around some word selection and some just passing through some scenarios and saying, hey, if this came into the practice, I might say this. And you might be surprised that some of the things that maybe you thought were not, I don't know, negative might be a little bit distant, or not so nice.
Listen, when you trust and respect one another and you have goodwill, and it takes time to build up goodwill, then you can have some issues that happen there. Let's talk about where the rubber meets the road in our own practice. I was asked to remove a failing implant from a number 4 site. Number 3 was not present, teeth had shifted, no bone at this area at all, sinuses close by. And I wanted Steph to come in to take a look at things. And this was a older patient, and in our practice, we're like, oh, you're going to get 2 doctors for the price of 1. I want Dr. Ganner, the periodontist, to come in and take a look. And then once you carry the story, how was your impact or insight different from mine?
Right. So it was actually great. Patients oftentimes when they come in for a consult, their perspective is limited and narrow. What Bob and I aim to do by giving 2 different approaches is say, hey, there's a few different ways to do this. And what it does is it helps us set expectations for the patient, and it really shows them, there's a lot of possibilities here. And it also helps us gauge the personality in the chair, what their spouse might be thinking, and there's an extreme benefit because as a periodontist, I'm going to have a different look-see based on the tools in my toolbox, just as Bob will.
And frankly, I think your specialty does a really good job at being mindful of inflammation and inflammatory systemic conditions and just how that's going to impact what we're going to do. You taught me a lot with respect to that. Okay, you can work on one site, but you have adjacent or semi-adjacent inflammatory conditions. You're setting yourself up for failure.
No, all of that's fantastic.
Oh, thanks.
And here, and another note on this, if you are a periodontist or an oral surgeon and you're going to be going to work with the other specialty, let's talk about interprofessional education. And this could mean even watching the other provider do a case, so you can understand where they're coming from. Where you might think an incision design is an absolute, like, why would you would always put it here, or you'd always drop a vertical on a certain case. If you watch the other provider, you're probably going to learn something about either a flap design or a specific case management.
No, that's a terrible way to say it. You're literally going to learn. Yeah, you're not probably. Yeah, I have, frankly, I've learned a lot from you.
Yes, I agree.
I'm hoping you've learned something from me. And even when you don't want a second opinion, we'll call each other in and just say, hey, I want you to see this. And this is why I'm doing it this way. Now, sometimes you'll say, okay, I hear what you're saying, but I'd still do it this way. And we can have, we have a fair amount of dialogue take place regarding differing opinions on things, and that's okay.
Right. And I don't want to sugarcoat this. It's not easy.
It's not easy.
It really isn't. And yeah, there are some days after clinic that, I've, especially for me though, I'm also out. I haven't been out more than 5 years in practice. Yeah. So there's a layered effect here. I'm trying to establish myself as a provider, which is super tough when you're in practice with an experienced oral surgeon. So there's a different dynamic there. If you're coming to the table as an experienced provider, maybe you will not have as many of the communication challenges as I have.
I agree, and I think many of the things you're talking about is just, one is OMS versus perio, and the other is just a newer practitioner versus someone who's been out for a while. I love to use Chat GPT for a variety of things, but I mostly like to use AI to help me think differently. By having a perio in the practice has helped me to think differently. You've changed my mind on some things. You have not changed my mind on other things. But it is, at the end of the day, it has made me a better provider for patients, and it's been more fulfilling. Tough, yes. Fulfilling, yes.
And I love how you say think differently. When we talk about interprofessional education and thinking differently from different perspectives, we are in a referral-based profession. Sure, there's some more direct-to-consumer marketing, especially with corporate offices. And if you are in a system that provides you those internal referrals, maybe this is not as important, but you need to educate your referral base and try to present this idea of a periodontist and the oral surgeon working in harmony. One of the first questions we get from referrals is, well, who do we refer to? And I'll just throw something out, implants. Who do we refer our implant cases to? And there's no right answer here, but one way where we have tried to show this unified approach is that we say refer them to the practice. And let Bob and I look at the tools in our own toolboxes, and there's an understanding that the patient's going to get the best in the whatever scenario walks in the door. So sometimes that's me, sometimes that's Bob. It just depends.
Which gets to ego.
Yeah.
Yeah.
And knowing when it makes sense to involve the other. And we, quite frankly, we do it a fair amount.
And for all, oh, sorry, Grant, go for it.
Let's let Grant